And thanks for finishing on the measurement piece, because it was a subject of a few questions earlier on. How do we measure success in terms of prevention methods? Okay, so we're going to take a different approach at this panel discussion. We're going to go straight to the floor. Some of you like to have a discussion first. Some of you like to just go straight to the floor at random. So I'll work with the roaming micers. So if you can just put up your hand and we'll get to as many as we can. I'm going to take 2 questions at a time. Just keep it to 2. So can I ask anybody to put up their hands? Yeah. Okay, can we just start table 12, please?
Good afternoon. Good afternoon, everyone. And I have 2 questions. And the first question is for Roger and Meta. When we talk about the dual diagonal and the screening and the brief intervention system. So we know that people with mental illness, most of the time they do not aware that they have a mental problem themselves, and they do not aware that they need support. In this case, right, and at the early stage before the screening, and how do we identify this problem, and how do we kind of identify, especially for kids or the special group of people need support, and what are there any actions being done, and is this programs for cell or dual diagonal system, is that involved in the evidence-based programs that we mentioned before, along with education programs, etc.
Okay. Thank you, Zin.
And my second question.
Sorry, Zin, can I just keep it to 1 question for now per table, because there was 2 questions there. I just want to get a few questions in from each of the tables, to be fair to everybody. Table 10, I think, had their hand up there.
Thank you. Can you tell us something about the outcomes of the programs you've been running?
Helen, specifically related to Sarah or Roger, was that both?
Anybody who's been running a program.
Okay. Anybody in the world or anybody in particular?
What is your evaluation of your program? How many? We know how many people go through, but what happens to those people from the brief, particularly from the brief interventions?
Thanks, Helen. Okay, first question. I'm going to put to Roger first. So Roger, it was around the areas in, if I'm doing it justice, dual diagnosis, early interventions. How do you identify, what's the triggers? How do you make the interventions at the right time?
Okay, so how do you identify dual diagnosis? I think in the first place, it's a mental health issue to start with. So I think people would start presenting with mental health issues that could be antisocial behavior. It could range with a lot of things like ADHD. They're just a whole bag of mental health disorders that can start with that. So that's one thing that I'm very interested in, because from a youth perspective, if you can get to that before they start misusing drugs or alcohol, so a lot of young people would be just trying to manage that. So I suppose if you can start with first identifying it and then saying, look, you could be at risk. Like most teenagers, as you know, when I go around schools, 85% of the students are already drinking alcohol at 15. So that's why that I think it's imperative to get into schools when they're young, so they can make informed choices and get the help before they start leaning on drugs or alcohol.
Okay, thanks, Roger. I'm going to ask each of the panel maybe on the next one, which is Helen's question just around outcomes. How do you measure effectiveness or outcomes of various programs that you will have each referenced, whether it's restorative justice or SARE or indeed the dual diagnosis? Maybe, Nicola, we'll start yourself first.
Yeah. So we have put in place an outcome framework that we worked with Queen's University Belfast on, because we're really conscious of measuring outcomes for people, and which will tell us the efficacy of that intervention in this space. So we are looking at consumption levels at baseline, and then we are using the National Drug Treatment Reporting System is already in place, and I know you'll have probably heard about that through the HRB they look at recording treatment episodes, and each of our SARE practitioners will be completing treatment episode records for their interventions, and that will allow us to look at where those referrals are going. It's too early to say what that treatment outcome will look like for people when they enter treatment. I mean, we know around 10% may need onward referral, and for the vast majority of people, the brief intervention in and of itself will be enough.
Just in terms of restorative justice, any evaluation, any assessment, measurements?
Yeah, thanks for that. Yes, so restorative justice evaluation is slightly complicated by the fact that it's voluntary, so you have to have an evaluation program that controls for the voluntariness. So some of those highest quality studies that I referred to before, what they do is that of all the people who are offered and agree to participate in restorative justice, of them a subset are offered restorative justice in practice and the rest are not. And then you're controlling for the fact that it's voluntary. And it being voluntary is important because agreeing to participate in restorative justice from a perpetrator's perspective could be indicative of a willingness to go down the road of reducing reoffending anyway. So what they look at then is either reconviction after a certain number of years or self-reported reoffending, and they try and look at desistance rather than just reoffending. So de-escalation of offending, by which I mean less serious offenses, or even deceleration of offending, by which I mean more gaps in between offenses. So these are all things that we look at when we're looking at evaluating reductions in reoffending.
Ian, can I just ask you, you have also some information in terms of the benefits for the individual?
For the victim?
The crime victim, yeah.
For the victim, yeah, okay. So two of the major studies there that I pointed to, one of them was in the UK, and that looked at cases which went to the equivalent of the circuit court. So a small percentage of the most serious cases, things like persistent burglary, aggravated assaults, more serious violence, and so on. And that found an 85% victim satisfaction rate. So even with serious crime, much higher satisfaction rate than with court. And then for victim recovery, one of the studies there was a randomized control trial at the University of Cambridge. That was the one that was called Angel and colleagues. And that one looked at burglary, aggravated burglary, and robberies and aggravated robberies. So again, what that one looked at was reductions in post-traumatic stress symptoms. So you get two groups of victims who are as close to identical as groups in all their characteristics, apart from the fact that one group participated in restorative justice. And then you compare their post-traumatic stress symptoms, levels of different types of symptoms over time. Because you'd expect post-traumatic stress symptoms to reduce over time. So you need a control group of people who did not receive restorative justice, and then a group of people who did, and it's comparing the group that did to the group that didn't, not just the reduction overall.
Thanks, Ian. Very interesting. Roger, effectiveness of programs that you're engaged in.
So I would evaluate the programs that I do. I've been evaluating them from day one. When I finished my honours degree in 2019, I was hoping to go on and do a master's in research on the efficacy of the Harmony workshops in Mountjoy Prison, but then we had this little thing called COVID, which just threw the whole thing up in the air, so I never got to do that master's. But as one of the speakers down there that was on the panel this morning said, I would love to do, I think it's very hard to gauge. I mean, the feedback that I get from the evaluations that I do in treatment centres and schools is very positive. I get a lot of emails and phone calls and social kind of media. My program is not a silver bullet program, in that it's going to like stop people from kind of taking drugs. I think when you're dealing with dual diagnosis, it has to be an integrative approach. So I'm definitely open, and I would love to do a bigger piece on research on the Harmony workshops to see the efficacy, because it does seem to work, but I know it is evidence-based as it is so far, but I'm always looking at making the program better.
Thanks, Roger. Okay, I'm going to go back to the floor again. Again, I'm not trying to restrict it to one per table, so if there's somebody at the same table, don't feel restricted. Table 9, table 9. I saw 2 hands, but yeah, one of you first, and then go ahead.
Thank you. Mainly for Ian, I think this question. Would you be concerned, or I would be concerned, that withdrawing legal sanctions from people who are addicted to drugs would have the effect of normalising drug taking and making it seem as though it's all right. Now, there seems to be evidence coming from Portugal at the moment that there's a slight rethink about what they've done, that areas are finding that people are gathering and having drug parties on lawns, playgrounds, public parks, and when the residents ring the police say, well, they won't come out, there's really no sanctions, we can't do very much. Now, if I'm taking drugs and I'm stopped by the police and they have section 29, and they can search me, I would have thought that the sooner that happens, the better for me, because they could direct me, to services or to Judge Kelleher's programme, or bring me through the courts, or indeed to prison, where resources could be put into the prison to help people. Now, I want to address just the thing about the criminal of this thing that would be hanging over somebody who ends up in jail and so on. Now, as I understand it, Senator Ruan has a bill which has gone through the Senate. It has got all-party agreement, all-party consent, and it's to go through the Dáil, I would expect. And that would mean that after a period of time, people who have been unfortunate enough to have a criminal conviction, they can have it mitigated after a certain period. And I'd be certainly all for that. But I'd be very concerned about having a free-for-all and just taking all sanctions. And just to finish, the COVID laws were very well kept, but by goodness, the guards were out. I never saw more guards around. And there were sanctions, and the sanctions were pretty stiff. So anyway, that's my point. I'd be a bit concerned about that.
Thank you very much. And well met. Well. Sorry, I know there was another person at your table. Was there another hand up at table 9? Adrian, sorry.
Yeah, sorry. My question was more based on Nicola. We were just wondering, how long does a referral take if a person needs a referral? And then basically the timeline from An Garda arresting until they get to the intervention, how long, what timeline would they be looking at going forward?
Thanks. I'm just saying we'll take one more question, table 3, because they were particularly for people. Table 3, Alana.
My question ties in there for Nicola as well. It's around, you said you have 9 of those SARE workers that you've got funding for. How many do you envisage you're going to need across the country? And how many people will they be able to deal with? And just, sorry, another quick question on that. What's the criteria? So Adrian was asking there about how long it takes for them to get to a referral. But then what's the criteria? Do they have to attend? Do they have to engage? What happens if they don't, I suppose?
Right,
Thank you.
Very good, Alana. Thanks. So 3 questions. First one to Ian first was the issue in terms of withdrawing legal sanctions and issues around normalising drug taking, etc., and the concerns around that, and examples of Portugal related. So Ian, can I put that with you first?
Yeah, absolutely. Thank you so much for those questions. That absolutely speaks to the heart of why it's essential for you to have criminal justice research expertise on this. So in relation to that, first of all, in terms of Portugal are having problems with drug use. They are having very similar problems to the problems in other countries where drugs are criminalized. So the evidence does not suggest that the legal model in Portugal of decriminalization is the cause of the issues that they're having in Portugal, because the problems there are very similar to other countries where drugs are also criminalized. In terms of whether the police can do anything if something is going wrong, the police here are never concerned about engaging in public order questions. So if people are having some big party outside and they're causing problems, they can still be dealt with in other ways, right? If there's other offenses going on there, aside from the say that they're having a party with alcohol and they're pissing loads of people off and maybe they're damaging things or neighbors are having problems, that's a public order question. So the police can absolutely intervene in that if there's a public interest and an interest of local victims in doing so. Withdrawing legal sanctions from people who are addicted is not going to incentivize more problem drug use. I know it's really counterintuitive, and I know that there can be a lot of fear based on the assumption that criminalization deters problem drug use, but that's really not what the criminological research suggests. Deterrence is about the certainty of being caught, not about the consequences of what happens if you are caught. Because if you assume that you're not going to get caught, or you don't care if you get caught, then whatever the deterrence that's in place, it's not going to change your behavior. So the sanctions really is not having an impact on behavior, apart from the fact that the sanctions can lead, as you say, to a criminal record, which makes it more likely that someone will engage in antisocial behavior in the future, even if they are eventually expunged, and I absolutely support Lynn's bill on that. And secondly, prison. It would be absolutely great if prison was a place where people could get the help that they need. But we absolutely know, and this is not just a problem in Ireland, this is a problem all over Europe, around the world. It would be great if prison was a place where people get the help they need. Prison absolutely makes all those problems worse. Thank you.
Thank you. Nicola, just three. There's three elements to the question, Nicola. How long for referral? 9. Approval for 9. How many would be needed, in your view? And the criteria for selection and monitoring.
Yeah. Thank you for those. Okay, so just to point out, I suppose, from the get-go that this is the health diversion programme isn't in place yet. We know that, and we've gone ahead to set up operationally so that it's ready when health diversion starts. So you're asking about the time from arrest to referral. While we're waiting for the health diversion programme legislation, those SARE workers are going out and making those connections already with the local Gardaí. So we would hope that that would happen as soon as possible and that the mechanisms will be in place to allow for it as well. And I can't put a specific timeline around that. It will look different in every area as well. It could be in a fixed base in some locations, it could be via outreach in others. That's very much how it fits with local services, is a key part of this. And likewise with, you had asked, the other part of your question was around time from the SARE brief of intervention into onward specialist services for those 10%. And look, we don't estimate it's going to be much more than the 10%. We know there's 40 years of studies about the efficacy of a brief intervention in reducing and stopping escalation of harmful drug use. But we do have key performance indicators around how long someone should be waiting for treatment, and this will fall in with that. So it will happen as soon as possible. And again, those SARE practitioners are based very much within existing services, so they'll have all those pathways already worked out by the time health diversion comes into place, and already have in a lot of cases. Then the other one you had asked about how many SARE workers will we need. We have funding and are putting in place 9, so we have 2 in place and 7 in recruitment, and we'll monitor how they're used and what the demand on them is. It's very, very difficult to know at this point, because it does feed into your other question around criteria. If someone has to attend, someone doesn't have to attend, they're given the option. And if they do attend, their level of engagement is a matter between them and the SARE practitioner. It's a collaborative conversation. It's up to them. It'll never leave the room, whether they engage or not. But it is a really good opportunity to discuss maybe some harm reduction advice, for example, or because a lot of people for whom SARE and brief interventions work really well are that cohort that don't come forward looking for treatment at all. So it's important that we can give that information and reinforce positive behaviours as well, but that'll be a matter between those people in that room.
And why is that important? That it's based on consent and confidentiality. Why is that important for the programme?
Why is it important for any programme? We're not mandating anybody to do anything health related. This is an option, and it's a new frame around looking at drug use and for people who don't necessarily need treatment. And consent and confidentiality is the cornerstone of all health services, so that will continue for this.
Can I just ask Nicola, just so we're all clear as members of the Assembly, when you say the health diversion programme hasn't been rolled out, it hasn't been rolled out because the legislation that was developed, or proposed legislation that was developed in 2017 and agreed by government in 2019 hasn't progressed anywhere? Is that's the reason why the health diversion programme hasn't progressed?
That's correct, but in anticipation of it, we have said we have the
No, I just want to be clear
mechanisms in
what's
place.
holding it up,
Yeah.
which is progressing.
Mhm.
Just briefly, Leanna, go ahead.
I'm just wondering, is it one per county you're looking for? Is it?
No,
one
it's
per
9, so it's one per community healthcare organisation region, and there'll be an additional one in Cork. So there'll be one specifically for health diversion in Cork, in addition to the SARE workers they already have for the court piece, because these are separate referral pathways. Yeah.
So do you envisage
Okay.
that's enough then? 9 is enough?
We'll have to really closely monitor it and see. That's what we have the funding for.
But if the health diversion legislation was in place, there could be more demand.
It could be.
You would expect.
Yeah,
you
but
would
I think
expect.
it's really important. Like one of the reasons why you monitor and evaluate things is so that you can put a case together if you do need more resources to go back and say, this is what's happening. These are the numbers. Here's who's attending. Here's the waiting list. Do we need to to bring more people on board? That's why it's important to have that monitoring piece in place.
Yeah, I'm just wondering why you don't have the numbers
Okay,
already.
sorry, Ilana.
Sorry.
I'll have to try. We'll try, and we can have
Not
more
for
conversation
meetings.
after as well. Rebecca, and then Noel, and then Aveline. Rebecca first, Noel, and Aveline.
Just speak to the point you mentioned.
Just 1 second, Rebecca. You just might get a microphone. Stand up. You stand up if you like. It's easier.
Nicola, just to address the question that you just mentioned about the importance of having the information, how can we have faith traditionally in the HSE that they don't already have that information? Surely there have been studies and research and figures and numbers. I don't believe that 9 individuals for 26 counties is enough. If even we were to say it was 10% or under, it's not enough. It's not adequate. Can we please take our heads out of the sand for once and for all? It's wonderful. We appreciate what you're doing here. It's great to have you on the panel, but it's time to actually stop lip service and tell us things are working. We've had people here talk to us about CAMS. CAMS doesn't work. We know that there are aspects of the HSE that doesn't work. We're here to discuss a health-led approach on a health service that is already unfit for purpose.
Noel, can I go to Noel, and then think, Aveline, do you want to come in as well?
Hi, Ian, a question for you. You've probably heard the various inputs from previous assemblies, from previous sessions with the Gardaí and with the Justice representations. Given that you're a kind of an independent party from Maynooth University, but you still have expertise in criminology and the justice system, was there any information imparted to us from those two, from the Gardaí and the Justice people, that you found particularly valuable, or conversely that you found particularly problematic?
Okay, and just one more question. The mic. Table 3 here, if we can bring the mic up one more.
Just for Nicola, just to ask, who actually are the people, the health diversion officers? Are they registered nurses? Are they anyone with a psychology background who's actually doing that work?
Okay, so 3 pieces here. One very strong statement, I think more than a question, as much as a question. Rebecca saying it just doesn't seem like 9 on the scale of what we've heard, and this is not, Nicola, your issue, not directed at yourself, but I think it's a challenge that statutory bodies and non-statutory bodies come to us and say, call the issues out, give us a chance to make the case for you, and for other people as well. But 9 just doesn't seem on the scale from everything we've heard here in the last few months at this stage. So I'm going to put that to you as well as the other one, just saying what's the specialist skills of the 9 recruits, and then we'll go back to Ian. That's okay?
Yeah, and I really appreciate that statement, you know, as a member of the public myself, as well as working for the HSE. I work in the HSE National Social Inclusion Office, so our concern and what we do is advocate for access and equity of health services for people who are marginalised, for vulnerable groups. And that includes people who use alcohol and drugs. And we've consistently supported a health-led approach to all aspects of drug use, and that's why we're involved in this piece. And myself and my colleague Professor Keenan have been involved in the Health Diversion Implementation Group since 2019, and it has been frustratingly slow. But we've gone ahead and put whatever structures we can in place with the limited resources that we do have. There's a lot of unknowns. The knowns are the efficacy of a brief intervention. And the knowns are that we can tell and we can support people who do need an onward referral. The unknowns are what those numbers are going to be, how long it's going to take to get this off the ground and running, and what resources there will be in the future for this. But like I said earlier, all we can do, you know, I mean, I think your guess that 9 practitioners isn't going to be enough is, this is a pilot. We have to gather the numbers and go back, and that's what we do. We do it really effectively in social inclusion anyway for all of our groups, and we'll continue to do it for this. And that's all we can do is advocate to get more resources and funding for an under-resourced area.
Just briefly, Nicola, on the type of skills, I think was type of recruits.
Yeah, I'm trying to remember now the
areas.
specifics of the job descriptions, but they will be people who have a counselling background and have familiarity with SARE as an approach in brief interventions, and who've worked with people before. It's not an entry-level position, so even the 2 that we have already in place are in North Dublin and in the southeast, and they have many years of experience of working with people who use drugs and alcohol already.
Just before I go to Ian on the next question, Eamon Meehan, who's at the back, Professor Eamon Meehan, Nicola's just referenced him. If I could ask Eamon, not known to be a man to sugarcoat it, any views on resourcing requirements based on the scale? And Eamon has been sitting in on every session, and thank you for that.
Thanks, Paul. Yeah, and thanks, Nicola. The presentation was really clear, and I think it puts out exactly what we expect the SARE worker to deliver. 9 SARE workers across the 9 CHO areas is a challenge for the HSE. It's a challenge for those workers to be able to, and I'm looking at some of the geographical spread we have in a CHO area. So we're looking at whether somebody needs to be in Castlebar on Mondays, that person needs to be in Galway on Tuesday, in Westport on Wednesday. So these are the type of things we're grappling with. We did ask for more resources. We got the resources of 9 workers. The other thing is that if we got more workers, if we had 18 workers that we had asked for, and they're sitting there waiting for the legislation to be in place, my fear would be, and having worked in the HSE for many years, that those 18 workers could be moved to plug a gap somewhere else, and suddenly I'd be told, yeah, the legislation now, we're ready to go next Monday, and I'll say, where are the 18 workers? And they say, well, they're doing X, Y, and Z, you know. So then I think that if we have 9 workers, we've got a pilot running. Nicola mentioned our KPIs. So our KPI is a key performance indicator. We do KPIs every 3 months. If our KPI indicates that this is overwhelming for those 9 workers after 3 months, and we have waiting lists that are building up, then we have a real opportunity to go back and say we need the additional money to have another worker in place, because the attention on this programme means that the government do not want this to fail for lack of funding. So I think if our KPIs, if our evaluation that's going to be put in from the start identifies that this is leading to a backlog, we'll be going back for money straight away.
Okay, but I just say one more time on behalf of the Assembly, it's absolutely shocking that a health diversion programme is our strategy, is our policy, and the legislation is sitting on a shelf practically since 2017, agreed by government in 2019. We're heading into 2024, and we're saying we have a health-led approach when we don't. So, you know, it's just...
Could I just make a point of clarification as well, because it came up at the last meeting. Some members asked, well, if there's a health diversion programme that is legislation is planned for, somebody asked the question, why are we here? And I think the answer is, if you cast your mind back to the workshop around alternative legal frameworks, health diversion was just one of 5 options, right? And there's more options, in fact, if you think about the pick and mix and the hybrid model. So there are a range of different alternatives that the Citizens' Assembly can recommend, notwithstanding the fact that Model B, as we call it, health diversion, is the one planned for by the government. That doesn't limit or constrain what the Citizens' Assembly can make a recommendation about.
Absolutely. Okay, Ian, just the issue of previous statements by Garda Síochána, and here, any issues that you take with any of them, or all of them maybe, but I think the question was posed in relation to some statements made by Garda Síochána, if I'm rephrasing correctly, at the last meeting, and if you've took any...
Yeah, and all the criminal justice stakeholders. So I think it was very useful that the Department of Justice recognized that there are going to be challenges around there being different legal frameworks in different jurisdictions. That is an issue. I think it was very useful for the prisons and the guards to talk about rolling out naloxone, which is absolutely an obvious thing that should be happening. So it's really great to see that's happening. I also think it was really useful that the guards talked about that they need to be able to stop and search people for drugs so they can harass young people in working class areas. That's very, very refreshing honesty from them. That's my argument. So I think it was very useful that they said that. I also, I think it's the wrong thing to do, but I think it's very useful that they said that. And I think it was probably much less useful, however, that there were very, very clear assertions made that criminalization deters problem use, and also that violence and criminality is worse here than in Portugal. Those statements do not align with the international evidence, with the criminological evidence. So I really appreciate the question. Thank you.
Okay, I'm very conscious of eating into your time at deliberations at the table, but I do feel there's great value in the questions and answers. It's raw, it's just issues being expressed and concerns being raised, so it's very good. So can I just thank our panellists, Roger, Ian and Nicola, again for presenting today.